So thanks, guys. Thanks for having us and inviting me to, introduce actually Brad's talk and some of his very interesting results. We thought to, give an introduction about MS, and I know the crowd here. Very experienced in probably in the medicine of pain. MS is a condition where pain is a very significant component, as we will see. It's a very important disease in Alberta because it's probably one of the highest prevalences and incidence in the world, and it's around, as you can see, around 340 cases for 100,000, and we have around right now. I would say 15 to 16,000 individuals affected in this province. That is a pretty significant number considering the population. Obviously, the distribution, as you can see, geographic distribution of the cases, and mainly around, the big cities like Edmonton and Calgary, and in the corridor here between the two. Obviously, because that's where most of the population is located. It's an interesting condition because it's affecting, differently from many other neurological conditions. This condition is affecting mainly younger population. So usually it's the age 15 to 45 that is the most affected. And you can see the majority of the cases, and this is from Alberta cases, the distribution, the highest is between 20 and 30 years. So it's a very young population, and so as you can imagine, any symptoms that affects this population significantly is going to affect their productivity, and so the impact, indirect costs of this disease are very high because of that reason. As you probably know, and let me see if I here, this is a disease that most of the times comes with bouts of neurological symptoms. This is the majority of patients. And these bouts of symptoms usually will come and then go after a few weeks or few months, depending on the patient. And sometimes these bouts will improve completely, so patients will present symptoms, and after they will get back to their baseline. After sometimes it can be again weeks or months, years. They can have another episodes, then there can be another episode of remission, and so on for some time. Around 70% or 80% of these patients that have these attacks and remission, they will then start having also accumulating some disability. So in other words, what that means is that when they have attacks and remission, they don't go back to their baseline, but they still will have some symptoms that will start to pop up, and in a time between 10 to 15 years with this disease, most of the patients will start having less and less of these attacks, and instead presenting more this kind of slowly progressive curve of their symptoms. And most of the times, the patients that you see with MS that have a progressive disease and mainly involvement of the motor system, and so you will start seeing patients that will start using a cane or using a walker as the disease progresses, and then eventually even the wheelchair. This graph shows actually the clinical course here, but is also showing the activity that happens. And this is really what is showing here is the MRI activity, and is the if we do repeated the serial MRIs in these patients, we can see that they have a significant underlying activity on the MRI, and this is why there is this iceberg here. What we see clinically is just the tip of the iceberg. There is lots going on in the brains of these patients, even during the times when they are not having clinical attacks. So this is an important concept. As you probably know from textbooks, the MS has always been considered a demyelinating disease, or a disease of myelin, where there are these lesions that are demyelinating lesions. You can see here a coronal section of a brain with the typical lesions that are usually around the ventricles, so periventricular lesions, and also there is a significant number that is juxtacortical. You see here the staining is staining for the myelin from the same sample, and you can see very well, the presence of the demyelination. And this is why, this was, one of the things that the pathologists have seen from the very beginning. So the disease has always been described, as I said, as a demyelinating disease. We know a little bit more now about this disease. We know that the disease is really, it is a demyelinating disease, so there is, the destruction of the insulation of the axons. But what we know right now, it's also that there is transection of these axons most of the times, and then there will have sometimes some repair mechanism, but this repair mechanism can be partial repair mechanisms, so the conduction along those fibers is never going to be back to normal, and that's one of the reasons why patients have sometimes remission, but not complete remission. So there is always some kind of cumulative damage that happens over time in these patients. And the idea of the axonal, as I said, axonal transection in these lesions has been around for a long time. Charcot in the 1800s described it for the first time, but for sometimes was forgotten, and nobody really paid too much attention to the axonal component, to the neurodegenerative component of this disease, till 100 years later, when Bruce Trapp in Cleveland rediscovered, if we want, the axonal damage, and I will show you a picture later on. But you can see here that even if we do, this is just an axonal staining, it's called silver staining for the axons, and you can see the difference in the density if we do the so-called normal appearing white matter here, or if we look at the axons within a lesion. So there is not only demyelination, but there is also significant axonal damage, axonal injury that accumulates over time. Why that happens? In disease like MS, so we have seen the demyelinating component, we have seen this neurodegenerative component, and I think this is a very interesting disease because one of the major other components of this disease is the inflammation. So we have inflammation and ongoing inflammation in the brain of these patients. This is a typical perivascular cuff that we usually see in the perivenular areas in patients during their acute lesions, acute relapses, and these are those lesions that if we do an MRI with gadolinium, we show that famous enhancing lesions, so that rim of enhancement. Usually the rim of enhancement is an indication of some active inflammation happening around the vessels. So the thing is, how do we put together then the inflammation with all this injury that happens in the brain? And there's been some different ideas about, how and why that happens. And one of the most important things that still we have not discovered yet is what is triggering this inflammation in this condition. MS is considered, as you probably know, an autoimmune disease. And when we call a disease an autoimmune disease, that means we don't know the cause of that. And so what is causing the activation? This is an idea, and this is a model, and probably is the most accepted model in terms of the inflammation, or what's causing inflammation in MS brain. It's called a model of molecular mimicry, and what we think happens is that everybody, as you know, has pools of lymphocytes or immune cells that can react against many different antigens, and this is the reason why, when we get an infection, usually our immune system is able to fight it, is because we have those antigens. But we have also a significant number of cells that can recognize some autoantigens. And one of the autoantigens, for example, or some of the autoantigens can be, for example, protein of myelin. But for some reasons, usually there are some mechanisms that keep this population under control, so-called mechanism of immune tolerance. And those mechanisms of immune tolerance will keep the immune system usually under control. So yes, we have this population of autoreactive cells. We all have here in this room. And the thing is that usually there are mechanisms that are keeping those population, as I said, under significant immune control. However, when we have a viral infections, there is always the possibility that a virus can have some commonality or antigen commonality, we call. So that means that there can be some sequences in the antigen that can be similar to an autoantigen. And so what happens is that when we have a viral infection, sometimes you can activate not only the response against the virus, but you could theoretically activate also an autoimmune response at the same time. So this is obviously a model that has been, in a way, shown in some of the animal models. We will hear more from Brad about that. But I think it's a very interesting hypothesis, if you want, that has not been proved, obviously, yet in the MS patients. But I think it's a very interesting model to think about. After we have this activation and this cross-activation, if we want, also these immune cells, autoimmune cells, the autoimmune cells will go and look for the antigen and go to try to destroy the antigen. So obviously, if the antigen is in the central nervous system, they're going to go to the central nervous system, and that's where the damage is going to happen. And so when we have this activation of these cells, obviously the immune system can make different decisions, different kind of activation. And usually the activation depends on the environment in which these immune cells are sitting. And so based on this environment, the cells can become what we call pro-inflammatory, as the ones that you see here on the left side, Th1 or Th17 cells. These are cells that are producing pro-inflammatory molecules like cytokines. Or they can be in an environment that usually is less inflammatory, and so they can differentiate in what we call Th2 or T regulatory cells, and these are cells that usually keep the inflammation under control. So in other words, in the context of MS at least, these are the bad guys, and these ones are the good guys. So when we try, for example, to treat this disease, we try to shift the cells from this pro-inflammatory phenotype to what we call an anti-inflammatory phenotype. So this gives you just an idea of a little bit of the immunology behind this disease. However, when these cells are activated, if we have these pro-inflammatory cells that are activated, as I said, they will go and look for the antigen. They will go, in the case of MS, into the central nervous system. When they go into the central nervous system, they will start recognizing the areas where the antigen is through some communication, probably through the endothelial cells. So this communication will tell these cells this is where you are in the right place. And when they are in the right place, they will start crossing the blood-brain barrier, and eventually they will go within the central nervous system. Now, when they go within the central nervous system, obviously they will look for the antigen, as I said, and if it's an antigen of the myelin, they will recognize the myelin, they will start destroying the myelin. Obviously, you can imagine that when this inflammation goes on, as everywhere else, when the inflammation goes on against one target, usually there is significant bystander killing, and there are some surrounding areas also that will be injured. And in this case, for example, even the axons and the neurons can be injured at the same time as the myelin. When that happens, and this is from that paper of Bruce Trapp that I was mentioning before, what happens is that you have all these blebs of the axons, so the axons will be all transected. And after you have this transection of axons, obviously, that's when the symptoms of MS will kick in. So what we think is that every time you have a wave of inflammation coming into the brain, and there is some transection, some injury, that's when the patients will manifest their symptoms, where they will present those symptoms. Now, the symptoms, as I said, they go as bouts, and in MS we can have different clinical presentation, different clinical phenotypes. We have the so-called clinically isolated syndromes, that is usually the MS at the very first onset. And the case I will talk to you today, I will present, is actually a case of a clinically isolated syndrome. So it's a patient that we've seen for the first time with this presentation. Patients with clinically isolated syndrome, if they have a typical presentation of clinically isolated syndrome, usually 80 to 90% will convert to relapsing remitting MS. And relapsing remitting MS are the 80% of the MS population. And these are the classical patients that have attacks and remissions. As I said, 75 to 80% of those patients, after 10 to 15 years with this disease, they will have less and less relapses, but they will be left just with this slow progression. They will continue having this slow progression. And there is a small population of patients, 10 to 15% of patients, that's called primary progressive. And these are patients that usually have just a slow progression. They will not have bouts of attacks and remission. They will have just slow progression of their symptoms. MS is, from a neurological perspective, is very interesting because you can have almost any neurological symptom with this disease. Obviously, you can have ocular manifestation. You can think about the optic neuritis, that is a very typical presentation of this disease, or you double vision with diplopia, vertigo, nystagmus. You can have bladder bowel involvement, and obviously for this crowd, pain is one of the symptoms that is very, very relevant and important in this condition. You know MS mainly because of the motor involvement that is very typical, and we see that very easily in patients. And we have a scale in clinic that we use. It's called EDSS, or Expanded Disability Status Scale. This was a scale that was created initially for clinical trials, but now it's a scale that we use to evaluate actually the clinical status of these patients. And this scale has 10 points on it, and every time we see a patient in the clinic, we will address the patients and we will do our objective examination and usually give a score based on this scale. The major points of this scale, I would say, are obviously if patients are on the lower end here, are patients that are almost have no disability, and they are completely able to mobilize independently. And as they move on this scale, obviously the grade 6 is when they have to use a cane, and 6.5 if they need bilateral help, so like using a walker, and then 7 is when they go to the wheelchair. And obviously you can see if they are chair-bound or if they are bed-bound, obviously that means that they have even more severe condition. And however, this scale is very skewed towards the motor symptoms. So in other words, we attribute points on these scales, in particular in the second half of the scales, more in relation to what the motor disability of the patient. For something like pain, for example, pain doesn't have a big role on this scale, so we need to use different scales to really measure pain if we do. And practically, we usually in our clinical practice we don't do that on an ongoing basis if we want. Pain, obviously, as you know, in the case of MS, it's usually a neurogenic pain, is a neuropathic pain. In most of the patients is described as in that definition of this burning dysesthesia. And however, any kind of pain is possible with MS. Usually you have sharp pain, tingling, numbness, or excessive numbness can be described by these patients. And one of the also important presentation that we see in MS is the trigeminal neuralgia. That is a very common presentation. And I'm not going to touch today on the trigeminal neuralgia. And I know yesterday there was a very interesting talk from one of Brad's trainees that is doing some very interesting studies on a model of trigeminal neuralgia. And we say that usually 40 to 50% are affected of patients with MS are affected by pain. I would say that in the clinical practice that's probably close to the 80%. There's any kind of pain, as I said, as can be painful numbness or tingling. So this is a case that I've just seen probably a couple of weeks ago that I thought was very interesting to introduce, and also the work that Brad has done in his lab, I think becomes really relevant to cases like these. This is a 27-year-old woman that came with actually her initial presentation was numbness and tingling that started in both feet, and then after a few days that extended upper to the waist, and then started also affecting hands, and then going up to her arms to her neck. After some time after a few days with this pain, she also started having a significant pain in the lower neck. At the same time, she also noticed some decreased balance, and obviously the balance was her main concern together with the pain initially. When she came in, she was treated with Solumedrol, the steroids that we usually use to treat an acute attack in this disease, and for 5 days. Very high dose. Actually, we use around 1 gram of Solumedrol for 5 days. And after 3 weeks, most of her symptoms had improved, in particular the balance, but she was left with a significant pain, and this was described as a shooting pain, episode of shooting pain affecting both lower and upper extremities. In this case, obviously, this was the first presentation, as I said. So this is a patient that we call a clinically isolated syndrome. I will show you the MRI. We treated this patient for the pain with gabapentin up to a dose of 900 per 2 times a day and some amitriptyline, and that seemed to at least take some of the edge off the pain, although it didn't completely resolve the pain. When we did the MRIs, and this is an MRI of the cervical spine, you can see that the lesion is very clear at this level between C1, C2, and you can see in the transverse that most of the inflammation seems to be in the posterior cord. That justifies, the balance issues that the patient had, and probably will justify also the pain. This is with the gadolinium, and so you can see the gadolinium is showing some enhancement, as I was telling you. So that enhancement is the manifestation of this perivascular infiltrate. So that means that there is some breaking of the blood-brain barrier, and obviously also some active inflammation happening in that area. We imaged the brain as well in this patient, and you can see the typical lesions that we usually see in patients with MS. They have this periventricular lesion, typically also an involvement of the structure of the corpus callosum here, and usually these lesions have like what we call dozen fingers, like they have this kind of flame shape that is very typical. And what these lesions are, if you look at very high magnification in the pathology, these are really perivenular lesions. They are just centered on the vessels. If they are active lesions, you will have that perivascular infiltrate. If they are non-active, then you will just have demyelination with very, very little cells there still present. Now, why these patients obviously had this significant pain? It could be related to the location and obviously involving probably the posterior column and some of the neuronal and probably the neuronal circuitry in the posterior area could be probably an explanation why she developed this significant pain. In the literature, there's been, and sorry for this slide, is very, very small, but these are some of the papers that have tried to localize the lesions and correlate them with the presence of pain. And so the majority of the papers have shown localizations that are in the posterior cord and involving the spinal cord, but you also have different lesions in different areas here that have been associated with things like trigeminal neuralgia, for example, or other symptoms. As I said, you will see that there's many cases of trigeminal neuralgia, and one of the things about MS that being periventricular and involving the fourth ventricle significantly, also the areas that are in the periaqueductal gray matter, where there are some of these circuitries that are involved in pain. I think it could also explain why it's so common also with lesions, just isolated lesions within the brain. In terms of treatment for this neuropathic pain, I have here just what we usually use in the clinic, and gabapentin and pregabalin as some of the ones that we use the most, sometimes in association with some of the SSRI. In some cases, we use some cannabinoids with not significant success, and then obviously, if the pain is continuous and not responding at our intervention, then we refer this patient to the chronic pain clinic. So I will leave now to Dr. Kerr to his portion of the talk. Yeah, after this. Thank you.
Okay, yeah, so what we do in the lab then is we try to understand pain at a more cellular level, molecular level. So as Fabrizio alluded to, we can sort of generate animal models which kind of allow us to get a little better understanding, a deeper look into what's going on. And the way we do this is with a very commonly used animal model that's been around for decades and decades and decades, known as experimental autoimmune encephalomyelitis. And as Fabrizio alluded to, the mechanisms that trigger MS, this animal model works on a very similar principle. Now, this model obviously is not MS, and in fact, actually, probably models maybe the clinically isolated syndrome maybe a little bit better, and some people have argued that. But what it involves is taking your rodent species of choice, and typically there's certain very specific strains of rodents which are susceptible to this disease, and you present them with myelin antigen. So we immunize these mice with a small fragment of one of these myelin peptides, and then in this model of molecular mimicry that Fabrizio had alluded to, that triggers this autoimmune reaction in the animal. And then in the right-hand side of those pictures, you see these characteristic or hallmark features of MS-like pathology, where you have infiltration of these peripheral immune cells and leukocytes. So you get T-cell invasion, a lot of macrophage, microglial activation, which then leads to, again, these hallmark features of MS-like pathology, demyelination, axonal injury. So this is what a mouse patient with this MS-like disease looks like, not using an EDSS score, but in the lab we have a different sort of clinical scoring feature, but again, based primarily on observable motor dysfunction. So on the y-axis of this clinical score, the lower the score, the more healthy, normal motor function of the animal, and then as you progress up to a grade 3 or a grade 4, that would indicate full paralysis. And so you can see, if you just look at the black 6 graph there, it takes about 10 to 14 days after you immunize this mouse before they begin to show their MS-like disease. And so this model, as I said, has been around for many, many years and has been used really to great effect to understand the immunology, the pathophysiology of MS, and a number of disease-modifying therapies have been developed through this, through the use of this model. But very little work had actually been done on the sensory aspects, as Fabrizio had alluded to. And really, one of the challenges that's presented to people like myself or my lab who are interested in sensory function in a disease model like this really stems from the significant motor impairment that you see there. Because, again, really, all we can really test, because most of the behavioral tests we use to assess sensory function require a functional motor symptom. So really we have a window from maybe day 0 up until that day 15 time point in which we can assess sensory function to an accurate degree, because after that the motor symptoms really do preclude any sort of assessment. But I can discuss later at the end of the talk some data we have that shows that actually these changes in pain behavior in this model do actually persist out into that phase. So nevertheless, that's kind of the clinical picture of this EAE animal model. And what my first student a number of years ago did, as I said, there wasn't a lot of work being done on the sensory aspects in this disease. So my first graduate student, Camilla Lahowski, that was really the project she was handed, was to take this animal model and ask that question. We know there's lots of motor impairments. We know this is a good disease which models MS, but does it actually reflect or demonstrate any of these sensory changes that one would see in the MS population? And so Camille generated a batch of mice with the disease and a batch of mice that were just immunized with the adjuvants alone. And what she found was, in fact, that the mice with EAE do develop very significant changes in their sensory thresholds. So on the left-hand side, that graph is the mice, their responsiveness to punctate mechanical stimulation. So if you're looking on the y-axis, she's presenting these very fine von Freiherr monofilaments and measuring the threshold, how much bending force is required to elicit a pain response from these mice. And so the white squares are the non-diseased control animals. And you can see it remains pretty roughly stable over the course of the experiment. Around 1 gram is where mice typically begin to say, ouch. In the blue circles, though, these are the mice which we've given this disease to. And you can see that amount of force begins to drop precipitously. So now we're into a state where a stimulus which previously would have been innocuous is now being interpreted by these mice as being painful in a sense. And the same kind of goes for the response to a thermal stimulus. This is a cold allodynia test. She just puts a little drop of acetone on the hind paw, and most mice don't respond to this at all. They just kind of flinch away because of the wetness of the stimulus. But if this is perceived as a little more painful or a little more discomforting, you'll see a more prolonged response to the stimulus. And you can see the blue circles, these mice with the disease, that response time begins to extend longer and longer. Now, the interesting part of this graph really is the timing of these behaviors, because, again, so in this shaded area, this is the time of clinical onset. So this is when these mice begin to become, when they would start turning up into a clinic saying, "Doc, my tail is paralyzed," or my feet aren't working. And we can see that their sensory thresholds are changing even before that period of clinical onset. So suggesting to us, at least, that we can have these changes in pain behaviors or in pain sensitivity, much like the clinically isolated syndrome, without necessarily overt axonal injury or even overt demyelination. And instead, we might have other mechanisms in place. So as Fabrizio alluded to, neuropathic pain in MS is typically ascribed to lesions affecting these tracts, the spinal thalamic tract or the posterior columns. But this data and some other anecdotal clinical evidence suggests that other mechanisms might also be at play which could set up some of these, that you could actually generate pain states without an overt lesion in those tracts. And the likely culprit of this would be the ongoing inflammation that one sees in this disease. And so Camille, again, took these mice, and this is the advantage, of course, of working in animal models, is that we can pop the hood and see what's going on at the cellular level. And so when she looked into the spinal cords of these animals, again, taken very early in the disease, right when those pain behaviors were beginning to change, she found very little evidence of demyelination per se or any evidence of axonal transection or injury, but the main thing you see is significant degrees of ongoing active inflammation, primarily or particularly in these regions of the spinal cord where sensory processing is occurring or is first initiated. So she's looking in these sections here, the micrographs on the right-hand side, is taken from, in what is in a mouse, the dorsal horn of the spinal cord. And you can see, this laser pointer is not going to work, in the non-diseased CFA control animals which only receive the adjuvant, there's very little or no evidence of T-cell infiltration into this region, nor is there very little microglia or macrophage activation or invasion. But again, in these mice with the disease, we can see significant amounts of T-cells and microglial macrophages sitting in and around these neurons, which are responsible for processing signals about sensory information, and particularly painful stimuli. So with this sort of cauldron of inflammation going on in this sensory region, these T cells and macrophages actually secrete, as Fabrizio mentioned, factors like these pro-inflammatory cytokines like interleukin-1 beta or interleukin-6, but also they're a very good source of the neurotransmitter glutamate, all excitatory factors which are known to activate and sensitize sensory neurons. And Camille went a step further and looked at the amount of neuronal activity going on in these spinal cords. And here she used a cellular marker known as C-FOS. And C-FOS is very handy because what it does is it can mark a neuron which has received intense or has received a stimulus and activated that cell. And so in the normal basal state, a mouse walking around in its home cage, such as in that CFA non-disease control, you see very little FOS expression. So, but typically, after you present a mouse with a noxious stimulus or some sort of activating factor, FOS expression rises quite dramatically. And so here in the B picture, what Camille is showing you is that these are mice with the disease, again, right at that early stage of the disease when pain behaviors are changing. We see significant amounts of cells which are activated, but these mice aren't receiving any overt noxious stimuli. These are mice that are just basically sitting around in their cage. And we could see that there's this ongoing spinal drive or activation of this nociceptive system, most likely occurring via those inflammatory cells which are invading into that region. Now, what that really sets up then is a scenario in which these cells can become sensitized. So in the model of central sensitization, which has been put forward to sort of account for these increases in pain sensitivity or pain hypersensitivity, we remember that glutamate, again, is kind of one of the primary neurotransmitters in this system, and that in a normal sort of day-to-day pain transmission, glutamate signals through a receptor known as AMPA, and there's a second class of glutamate receptor known as the NMDA receptor, and it's typically very silent in these normal scenarios when there's very little drive to the system. And that is due to some biophysical properties of that NMDA receptor channel. But in cases or scenarios where sensitization can occur, following a peripheral nerve injury, for instance, or let's say in a state where there's significant amounts of inflammation and increased amounts of glutamate driving the system, what that can do is alter the membrane properties of the cell and recruit this NMDA receptor into play, allowing excess calcium into the cell and effectively just elevating the output and responsiveness of all of these neurons. So in fact, generating this state in which pain transmission can be amplified, if you will. And so Camille followed these studies up by looking exactly at the activation state of the NMDA receptor in these EAE mice, and that's exactly what she found. Again, without any overt noxious stimulation, just in the basal condition, what she finds is that the overall level of activation or activation state of a particular subunit of that NMDA receptor is significantly increased in these mice with the disease, again, at that time period when these pain behaviors are being displayed. So Camille has shown that this EAE model then presents this really nice kind of signature of central sensitization going on, likely as a cause of that ongoing inflammation. So Fabrizio had talked about the primary sort of modes in which neuropathic pain is treated in the MS clinic. And of course, there's been a number of recent sort of studies looking at more experimental therapies and approaches to try to treat pain in MS. What I'll do is just end with some recent work that was just completed by another graduate student in my lab who just graduated this past summer, Curtis Benson. And what Curtis wanted to do was to assess a non-pharmacological approach. Is there any way we could sort of get at and modulate the pain behaviors in this EAE model without any sort of overt pharmacology? And so what we decided to do then was to use exercise and see how does exercise modulate disease outcomes and pain behaviors in this model. So Curtis and I went out, scoured the pet stores and bike shops of the city, and we decided to build a mouse gym. So this is our little gymnasium that we built. We built individual little running wheels. We fitted up some of the standard mouse cages with these little mouse running wheels, rigged them up to little bike odometers so that we could track how far the mice would run in a given workout session. And that's exactly what Curtis did, was he gave these mice a prescribed amount of exercise every day. So a lot of people doing exercise studies will just kind of give the rodent, the mouse, or the rat sort of free access kind of any day for all day. What Curtis wanted to do was do a more clinically relevant, to his degree, 1 hour a day exercise regime. So the mice came into the room, he let them go on the wheels. They could run as little or as much as they wanted over an hour and then return to their home cage. And rodents are excellent runners, and they run very instinctively. Over the course of an hour, you can see in the gray bars, this is the week preceding the clinical onset, before the mice get sick. These mice run typically about 1 kilometer over the course of an hour, and if you leave them overnight, they will run about 10K a night. So those little legs can carry them basically to Calgary over the course of almost a week's time. So the mice run, as I said, right up until disease onset, and even at disease onset, that clinical grade 1 on that scale, their hind limbs are still functional. It's really just a weakness in their tail. they're still getting onto that wheel and doing their best to get their exercise in. But then the running then precipitously will drop, obviously, as their legs become weak or paralyzed. And again, though, once there's a little bit of a remission, as Fabrizio had alluded to in this disease, when they can regain some motor function, they do seem to get back up on the wheels and keep trying to run. Now, what this exercise regime had the effect of doing, it couldn't obviously, at least the 1 hour a day of exercise, wasn't able to prevent the disease from developing at all. But it did have this significant delay. So we found that the mice which were given access to these running wheels had about 3 to 5 days longer in which before that the symptoms actually kicked in. So I'm not really sure what that translates to in mouse years or into human years, but it was a significant sort of delay in the presentation of the disease in these mice. But more importantly, when Curtis kind of went and followed up on the sensory function, doing that von Freiherr test, he found that as we predicted that the mice with EAE and not having any exercise developed that significant hypersensitivity to tactile stimulation. But the mice which were allowed to run, there was a significant attenuation of that hypersensitivity. So they didn't develop as significant amount of a pain phenotype as the sedentary controls. Now, the mechanism in which exercise is acting at primarily seemed to be, and it was kind of observed obviously from the delay in the disease onset, is that the exercise seems to have a very significant anti-inflammatory effect. And so if we sort of cycle back and look at a mirror of Camille's data, what Curtis found was those mice which were allowed to run had diminished overall inflammation in that spinal dorsal horn region, in those sensory regions where pain gets initiated. So the green in the bottom pictures on the left are classical EAE animals with lots of T cells infiltrating into the dorsal horn. Again, very early in the disease when pain is just being initiated. The animals which are allowed to run, we see the numbers of those T cells significantly suppressed. Similarly, with those microglia macrophages, again, in the EAE mice, we see a significant inflammation ongoing, and then that's dampened down and suppressed. So again, suggesting that you would have less ongoing drive of these pro-nociceptive or excitatory factors coming into the spinal cord, leading to this pain. And in response to that, then, if we looked at the CFOS levels, again, as the marker of neuronal activation, you could see those mice allowed to run 1 hour a day have significantly suppressed amounts of CFOS compared to the mice with EAE alone. And then just to wrap up that data, Curtis looked again at that indicator of the NMDA receptor activation to see if that signature of central sensitization had been altered. And if you look at the bottom in the colored panels, the green is indicative. He's using a different technique to Camille here, using the cells as his readout for NMDA receptor activation. So the green cells are all activated NMDA receptor components, and we can see that that's significantly suppressed in those animals which were allowed to run. So taking that all together, I'll wrap up now. We can come back to Fabrizio's diagram about the T cells and what exercise is most likely doing in this scenario. And this is where a lot of the ongoing work in the lab is focused, is trying to understand exactly how the exercise is affecting these T cell populations or this inflammation. And there's a number of possibilities. There is some very good evidence in the literature, at least from T cells out in the muscles, that exercise tends to promote that shift of these T cells into that anti-inflammatory phenotype, so that Th2 component. So with lots of exercise, the body seems to, the T cell population tends to skew out towards these more beneficial, good guy-like T cells producing anti-inflammatory factors, likely maybe to suppress or dampen down the pain behaviors. But the alternate scenario is that the T cells with the exercise might actually be still skewing towards that Th1 phenotype, but producing less of some of the bad factors which we know are pro-excitatory or pro-nociceptive, like interleukin-1 beta or TNF-alpha. And so that's what's ongoing in the lab at the moment. Another student has picked up this work and is examining these responses. So I think that's about it. I should acknowledge the two folks who carried out most of that work. The beginning bit, as I mentioned, was from Dr. Camille Olachowski, who graduated a few years back and is now off in medical school pursuing her MD. And the work on the running wheel was carried out by Curtis Benson, who just graduated this past summer and has now moved on to Yale University and is pursuing his postdoctoral studies. And I guess we have to thank some of the people who also contributed to the work, and primarily the people who pay the bills and keep the lights on in the lab. And I think that's it. So if you have any questions for Fabrizio and myself, we'll be happy to take them.